Welcome to The PA is In, the show created by PAs for PAs, where codependency with your supervising physician is a thing of the past, optimal team practice is the future, and physician associate has taken the place of physician assistant as the professional title of choice. I'm Tracy Bingaman, and I'm obsessed with redefining what success as a PA looks like and what it feels like. Here you'll find the mindset shifts, systems, and processes I use to escape healthcare burnout and integrate my work into my life. Work-life balance is a myth, and an integrated life where you thrive professionally, not a balancing act, is the goal here. My mission is to help you to grow into a unicorn PA who loves their job, has abundant energy, time to spare, and work-optional financial freedom. The PA is in. Welcome back to another episode of The PA is In. Today, I have a guest, Thea Nolan. Thea is an interventional radiology PA who you might remember from being featured in the 2022 AAPA PA Week news features. Thea was featured because she identified devices that recalled and saved the lives and helped to prevent complications in tens of thousands of patients across the U.S. Thea is going to share with us her experience as an interventional radiology PA and also how it went when she identified that those devices were faulty and what she actually had to do to get something to happen so that patients wouldn't be harmed in the future. Without further ado, here she is, Thea Nolan. Thea, welcome to the show. Thank you so much for being here.
Thank you for having me.
If you could just tell us a little bit about you and what you do as a PA as an introduction.
Sure. So my name is Thea Nolan. I am an interventional radiology physician assistant. I practice in Massachusetts at UMass Memorial Medical Center. I've been a PA since 2012, but I've been in interventional radiology since 2015. And I personally think it's the coolest job ever. I do vascular access procedures such as port placements, PICC lines, tunneled lines in the IJ. We use ultrasound guidance and fluoroscopic guidance to place the devices. And then I've also cross training in body interventional radiology, doing biopsies, percutaneous biopsies, as well as CT guided abscess drainages, ultrasound guided abscess drainages. It's kind of, like I said, the coolest job ever.
So I would love it if you could tell us a little bit about what you did before and how you got into IR. I feel like there are PAs working in IR, but there's a lot of question of like, do you do surgery first? How do you get into interventional radiology? So what was that path like for you?
Yeah. So my first job out of school, I placed PICC lines. The job that I got into was not the job that I thought I was applying for. So I applied for, I knew I liked something surgically related, but, they had this job and it was the first time they were hiring a PA. And so I took it, and it was not at all what I had in my mind is what the job would be, but it turned out to be such a blessing in disguise, because it allowed me to learn how to do a procedure on somebody who is staring right at you. Like there's no sedation, and you're talking them through the process. And it was a wonderful learning experience, just from how to approach your patients. But it also gave me a lot of the skills that I needed to move on to interventional radiology. And one thing I should tell you that in between, I kind of felt like I had peaked there. Like there was after 1 year of doing nothing but bedside lines, I was a little bit bored, and I felt as though I was losing kind of the medical aspect of things that I had worked so hard to obtain during PA school. And so then I was approached, and a colleague said, "Why don't you come and try out cardiac surgery?" So I split my time between the two. That was not for me. I did it for 3 years. Um, I tried. I really did try. It was not for me. It was not something I could do part time. But I learned what I loved, which was the procedures. And so that's kind of what helped me transition into interventional radiology.
So in IR, do you feel like you're using that medical aspect of your brain and your training? Do you feel like are you pre-upping your own patients? Are you like risk stratifying them? What does that look like for you?
Yeah, actually, there's a lot of medicine in interventional radiology, a lot more than I would have anticipated because we touch every facet of medicine, like anything from trauma, OBGYN, urology, nephrology, vascular oncology. We do a little bit of everything. So the learning curve is something I'm still a part of that curve every day.
Yeah. Yeah. Do you I sort of want to ask like what the procedure is for you getting comfortable doing a procedure. So when you're first onboarded, like obviously you were super comfortable doing PICC lines, but if you hadn't done some of these percutaneous biopsies or port placements, what was the orientation process to go from, hey, I've never done this procedure to I'm comfortably doing it independently?
So I can let you know when I get there, or when I get there 8 years later. Um, but no, I mean, there's certainly some procedures that I feel very comfortable with, and I think that um, allows me, if I'm feeling comfortable with my own skills, then to um, provide that level of comfort and confidence when I speak to my patients, when I'm consenting them. But I would say there's a lot of being comfortable with being uncomfortable. And that was a learning curve for sure.
Yeah. 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 I think there is this point where you're almost ready, where you understand the procedure, where you've seen it done, where you've maybe done one with someone standing right there, and then you're doing it sort of like without training wheels on your own, and you think you can, but you don't really know that you can, and you just have to do it anyway.
So it's interesting. In vascular, like there's three main procedures that you get credentialed to perform. And we both know there's a difference between credentialed and competent, right? And then confident on top of all that. And so um, I had a really great preceptor. He was very, very hard on me, but in the end, I know that I am a better PA because of him and because he was so tough and had such high expectations. I have high expectations of myself as well. But then when I reorient or orient new hires and I'm training them, that's kind of the level that I hold them to as well. Um, However, on the body side of things, there are 17 procedures that we do. And so it's not just a simple, procedure A, like we'll talk about a port, for example. Um, it is a surgical procedure. It does build upon tunnel lines, if you will. So we're using ultrasound, we're accessing the internal jugular vein, and then you're using fluoroscopy to watch your wire, making sure that you're going through the heart, you're staying in the venous system. You want to be in the superior vena cava, and then you want to show that you're in the inferior vena cava to prove that you're venous and not arterial. Super important for vascular access devices where you're infusing medications. Um, and, the nuances and technical challenges that you can encounter during those procedures, it takes years to get comfortable using the different wires and catheters and navigating, various types of anatomy. Those are just three procedures, right? And then I go over to the body side and it's like I've started all over again. And so that was definitely, when you consider yourself to be um, very competent and you know that you're good at your craft, and then to kind of eat that humble pie again and again and again and again, it's like, yeah, it's tough. It really is.
I mean, I think that is an important reminder that we are all human and that you can be really great at the thing that you do. Like so confident, not
Yeah.
like overconfident, but just like solid, right? I know how to do this. I'm very comfortable. And then someone is like, what about this? And you're like,
Hmm.
like that is
Yeah.
something I would have to learn. And that is
Yeah.
true regardless of the letters after your name. That's not specific to
Yeah.
PAs. That's what it's like being a provider. And
Yeah.
even if you didn't change a thing and you only did those 3 vascular procedures, in 2 years, someone's going to invent a new type of port, right? There's going to be
Yeah.
new things that are coming along. So I think you can never be complacent and for that reason, confidence is an ever moving target, right? You could be confident
Yes.
in things the way they are, but like things change or the way that we do it or standard of care changes. And you always have to be on your toes and ready to say, like, hey, here's the way we've always done it. But this is a new thing that we're going to do or trial or try or learn.
Yeah, actually, it's funny that you mentioned that because that's something that happened with us when we switched over to a different type of device, and it was still a power injectable device. It functioned very similarly to a previous one that we had used, except the way that we placed it was different. And it was just after 5 years of muscle memory of the same type of steps over and over. I was like, wait a minute. And to, learn a new technique and then just be able to speak to that particular device and, educate our support staff or people that might be using these devices not within our department and, help them troubleshoot things that they may be encountering. It was just a new learning experience and just building upon something that you felt like you had like cornered the market on, if you will.
Yes. Yeah, I think that I've got it. We want that, right? We want that check mark. We want to say like I'm signed off, I'm good. And then sort of the universe is like you're not or like here's a little curveball. We always have
Yes.
to be on our toes for that. So while we're talking about devices, I would love if you would share the experience that you had with a batch of devices that wasn't functioning correctly and what you did about that.
Um, yes. In 2001, my day started like any other day. I was called into the room to assess a patient with a question of a malfunctioning device. And like I do for all of my patients, I looked at her medical record prior to entering the room. And I noticed that the last note from the oncology nurse had mentioned that when they aspirated the port, that the blood return was dilute and it was described as a swirling in the sample tube. And when I read that, my mind immediately went to contrast, and I thought, that's interesting. And so then I looked at the last imaging study that they had, and I saw that she had had a CT scan with contrast, a power injection through the power injectable device that she had. And there was some leakage around the catheter. So then, with that information, I walked into the room, and when I did the dye study, I saw that there was a small leak. And so the patient didn't have any signs of being immediately, needing it to come out that day. She wasn't NPO, she wasn't prepared. I brought her back right back the next day. And when I opened the pocket, I said, huh, because I saw the reservoir or the container that the contrast goes in, or your chemotherapy or whatever agent that you're using was literally blown out. And I kept the device. And I kept the device because my colleague had just gotten signed off on placing lines. And, one of the first things that we ask when there's a complication with a patient, whether we want to ask it or not, is who did the procedure? Whose procedure was it? Because you never want it to be yours. And when for my colleague, she was just devastated. It was like the first port she had put in by herself, and I kept it to show her this is not anything that you've done. I've been doing this for 8 years. I've never seen anything like this. This was a 1 in a million thing. And I'm so glad that I kept that device because I got a call the next day from a colleague, and he said, I was told to give you a call. I had another patient over at our sister hospital. We just took a device out, and it looked very similar to the one that you took out yesterday. And I asked for the patient's information, and I looked up the medical record number, and I found the lot device number, and like the hair on my arms stood up. And because it's one of those things that you think that I'll I'll never see something like this in my life. And you think, could it be? And then patient number 5, 6, 7 came in, and it was um, it was a really interesting experience. It changed my view on healthcare for forever, and how our healthcare system works. And I can talk about that a little bit, um, because it was really difficult getting anybody to listen to me or do anything about it. And I had a moment of questioning myself, like, you know, is is it is it me? Like, how can I convey this to risk management? And I'm doing all of the things that I'm supposed to. I'm putting in the SIRS reports. I'm following up with people, and crickets. And so after 2 weeks of this, and finding out, I knew there were more patients. I knew, and I knew in my heart, every fiber of my being, I knew I was doing the right thing. And I finally, on a Friday, called my department chair, who in the 8 years I'd worked there had maybe seen me twice, but barely knew my name. And I said, "You need to do something about this today. And I would like an answer back today." And, you know, he did. And that led to literally a nationwide recall of tens of thousands of ports.
We interrupt this broadcast with a very important announcement. You are not making enough money. Your practice and your physician do not understand the value you are adding to their patients, and therefore you aren't earning what you're worth. If in the past your requests for a raise have been met with one single word, no. If you're working more hours than ever and seeing more patients, but you're not making any more money and you're feeling pissed about it. If you feel like you've hit the ceiling of your income band, this guide is for you. I've compiled the 5 most costly and most common mistakes that PAs make when asking for a raise, and I've told you how to avoid them and what to do instead. Download your free guide at tracybingaman.com/mistakes. And I think we as providers have this inherent trust in the system, not a blind trust, but just in general that things have been quality controlled, that they've been inspected appropriately, that they are, that we're placing them safely. And that when this happens, that we're like, wait, what? Like this is supposed to be, you know, nothing is perfect, right? Nothing is without flaw, but we just have said like, hey, we trust in these devices, right? We trust in the company that makes them. We've used them for years. They've always been reliable. Patients don't have problems with them. And then when someone is, it's like, wait, hold on. And it can't just be me, right? And I think that does happen to us a lot. We're like looking around like, this doesn't seem right. This doesn't feel right. Something needs to be done about this. But if everyone else is nonplussed and no one else is concerned, you're like, no, wait, what? Like
And,
it's
yes.
make you second guess yourself for sure.
And that's that Friday. I'll never forget that moment. Like in my office, like I'm staring at 4 of my colleagues and saying, every one of you has implanted one of these devices into a human being. Like, I cannot be the only one that's concerned about this right now. How are you all not freaking out? And and I wouldn't let it go because I knew it was the right thing. And that's who I am, and I'm so glad that I followed through, and you know, it has forever changed me. And I I have a lot less self-doubt and that imposter syndrome now. And I just feel like I know what I know. I've been doing this a long time, and I know what I know. And I knew something wasn't right, and I didn't let it go.
And this matters in so many different situations, but with this one in particular, it's the tens of thousands of patients who had already had that device implanted who maybe weren't leaking yet or weren't aware or were going to get some chemotherapy that was going to extrav, right? So like number 1, people with the existing device. Number 2, people who haven't yet had the device placed that is potentially in that same lot of manufacturing that we would have had like unknowingly kept doing it, right? So unless we stop it, we're going to keep going the way that we've always done things. And that was to the detriment of those patients if nothing was said or done about recalling them and getting them out of that storeroom where someone is about to put it in.
That's a really interesting perspective. I hadn't actually considered the patients that would have been affected that had not. And that's even more powerful, like like saving the unknowing, that's an even greater way to think about it.
Because the ones that already had the device in it, there was nothing we could do about it unless someone else had identified it sooner, right? So like we didn't know what we didn't know up until the point where we knew. Then once you know, you take the steps to rectify what you've done to those patients or what's, the problem with the device that's happening. But there had to have been devices on shelves that were ready to be put in patients that were recalled as well.
Yes, yep, there absolutely were. So the lots that had affected us in Massachusetts, I think there were two or three. However, I think when it was all said and done, there were 10 or 11 different lots that were recalled. And the interesting thing about this particular device issue is that it was luck of the draw in the sense that it wasn't at the just regular if you're accessing it or giving a non-power injected medication through it, the device wasn't failing. It was at the time of power injection because the pressure has to get to a certain point inside the device so that the contrast can flow. And there's a little piece of metal in there that's supposed to deploy when or be triggered rather when the pressure gets to that point. And it sounds like that's what the piece that was missing, but it was only missing on some particular lots on the medial lumen. So if you had it or the left lumen rather. So if you had the port placed on the right side of the chest and you had it accessed on the left side, then you were okay. But if you had it on the left side of the chest and you had it accessed, on the lateral side rather, I'm trying to say, it was just, and that was like another thing. So while we were going through this process, like looking, well, what about Mr. Smith over here? Mr. Smith has that lot number and he had a CT injection. And so it was kind of figuring all of this out after the fact. And so that was some of the things that led to, well, wait, we don't want to be like the whistleblower. We don't want to be the one
Unnecessarily,
that's,
right? Yeah.
yes, yeah, we don't want to sound the alarm, but we knew, I knew.
And I think there's something to be said for the fact that in healthcare, how do I say this? There are a lot of things that we do that are not great. Culturally, it's not great. So, there's things that are happening all around you that you're like, I don't necessarily agree with this, but this is sort of how it's done at this institution. And this is just such a good
Mm,
reminder that, like, when something is wrong, whether it's something is wrong with the device, something is wrong with the way someone is treating someone, something is wrong with the way that patients are getting cared for. When when you're going home and it's like keeping you up at night, like this thing is happening, I know it's wrong. I don't know, why I'm the only one who thinks this is a problem. Like a reminder to raise your hand again and again, like loudly and repeatedly, and say, this is not okay, right? This is happening to patients. This is happening to providers. This is happening to staff, whatever it is, to say, we have a culture of, openness. We have a culture of communication. But that's not happening, right? Because we have all of these things that we say we're about, right? All of these networks that say they're about patient care, that are like focus on the patient. And then when you're there, you're like, we are not. That is not
yeah,
happening.
yeah, it was so, I can't really, sometimes I fail to find the words to explain what that moment in my office alone on a Friday night at 7 o'clock, 2 hours after I'm supposed to be there, was like to me. It was like everything I knew about healthcare. I thought we were all in it for the same reasons, right? We all have the same thing in mind, which is to provide the best, safest, like highest quality patient care. And the support system that I thought was there to help me provide that care, I was actually, that was not the case. It was insane to me. It really just, it blew my mind. But as much as it changed me, I've grown so much from this experience, and I think I've been able to, like just yesterday, I was at an AAPA sponsored event. It was nurse practitioners and PAs, but it was
Oh,
sponsored by
yeah.
AAPA. Yeah, and it was talking about like innovative thinking, and it was just a wonderful experience. And every person that I spoke to yesterday, I made a point to remind them that we all have a voice. I didn't bring up the port story to anybody yesterday. I didn't say a thing. I just really wanted everybody to know that they're important and that they have a voice and there's strength in numbers. And if you feel something is not right, the only way that change is going to come is if you advocate for yourself and for your people and for your group. And I try to remind people of the little victories and how it's the little victories that add up and how we get ourselves to where we need to be.
So I think that is such an important reminder. And I'm wondering if at any part in this process you felt like either you weren't being taken seriously because you weren't a physician, or what advice you have to the person who is like, but I mean, my surgeons are okay with it, or my physicians seem fine with this, but I know it's wrong. What advice do you have for that person who holds a title different than physician, but is still really wanting to say something and make a change, but maybe second guessing themselves because of that position that they hold?
I would say if you see something isn't right, you just have to speak up. And, it is really hard, especially when you come from a surgical hierarchy, if you will. Like I I always loved surgery related subspecialties, and I always knew that was something that I wanted to do. And so I was very accustomed to you know, your attending physician says XYZ, and this is what you do. Now, if you have a question or if you think that, you might want to make a suggestion, I would like to think that the people that we work with are open to said suggestions, but we all know that there are people who are, no, this is the way I'm going to do things. um, and my direct report, if you will, the person I was supposed to report these things to, I did over and over and over, um, and nothing was happening. And so that was a very uncomfortable step for me to know that I was stepping over to have to go to that next level. Um, but I did it because I knew it was the right thing to do. And it did give me pause, I'm not going to lie. Um, but I did it because I knew it was the right thing to do. And when I was sitting there on that Friday, and I keep a personal patient log, right? And so just from my own patient log, I knew I had 17 patients that had that one log, my own log. And I knew that the log that we had in our department had only gone back to January 1st. I knew that we had another one, but I was somewhere that I didn't know of at the time. And so I knew that patient zero had her port placed in November. So I knew that there were a lot more that we weren't. And I'm one hospital of five in my system that we're all using the same devices.
Yeah. Yeah. It's huge.
So,
And I mean, I think there's power in those numbers to support the data, but even if you see one patient being mistreated, even if you see one thing, like that is still worthy of raising your hand and saying, hey. And the reason that it matters is because like those things are tracked. So if you say, hey, I saw this person behaving in this way, it's not okay. And then someone else says, hey, I saw this person behaving in this way, and it's not okay. Because sometimes I think we discredit, like, oh, it was just a bad day. We make an excuse for other people. Um,
yeah.
but also we too need to hold other people accountable for following through on what they
Yes.
said, and for like, hey, where was that? What did we do about that? Was there a consequence of that?
And that was the real, like, when I called risk management for the third time, and it was again that Friday. It was like that Friday that my world came crashing down. And I said, well, I'd like to call my patients. I'd like to call my patients and let them know what's going on. And they said, you can't do that. I said, what do you mean I can't do that? You can't do that. And I was like, what? And then I had the list, Mr. Smith, he's fighting for his life right now. He's in the ICU and he's got stomach cancer and he's due for a CAT scan. He's on the schedule tomorrow morning. I had like a whole list of people that just within my list were actively having treatment and had procedures and such scheduled in the next week. And I said, I, no, no, I'm not doing that. Yeah, that's not okay. I'm not taking that for an answer. And um, at some point, I said to myself, "Who are you?" Because I am a rule follower. Like I do believe in the hierarchy. Again, surgical, surgically trained. Like classically trained in the hierarchy of what we do. No, I really just I knew it was the right thing to do, and I wasn't going to take no for an answer, and I haven't looked back. But it is funny. I have gotten right after it happened. There was no retaliation from my institution. Okay, I would like to be very clear about that. My institution was very supportive, but individual staff members, not so much. And it was really disheartening, I guess. Like in a sense, it was like people said, "Oh, she's getting all the credit for it, or we're doing all the work, taking all the ports out and replacing them." And I'm like, no, like the effect that it had on the patients was not lost on me. Like I understood, like yes, we could have, we've identified a problem and are potentially um, going to reduce harm by having these devices not malfunction by explanting them. If, so we had to reach out to all the oncologists and say, this is the situation. If you think your patient still requires treatment, then we're happy to bring them in, exchange the devices. Um, you know, that's a lot for somebody who's undergoing active treatment. Like that was not lost on me. I felt for those patients. So it was like, yay, like we worked really hard and figured this out, but now we have this huge population of patients that we have to get them the devices that they need.
Yeah. And it's interesting to me, one would hope that when something like this happens and you do the right thing and identify the problem, and yes, it generates work, but the alternative is like harm to patients. So who gives a shit about that? I mean, I get it. Everyone's too busy for their own good. I understand that. However, you would hope that you would be, as a healthcare community, that people would be cheering you on, that people would be saying like, oh, I wish I had done that. I'm glad that you raised your hand and said this was wrong. And instead that they're like, she did this for credit. Like that's such baloney. Like it just like the culture is so bananas. If you only take one sheet of paper to your next negotiation, let it be the PA Pay One Sheet. It's a tool designed to walk you through setting up the ideal outcomes, assessing the situation you are negotiating in, and it even includes a reminder of which negotiation skills you can use. Stop what you are doing. Download the One Sheet, print it out, fill it out, and literally bring it to the table with you when you are negotiating next. It's designed specifically to work in healthcare settings wherever you are. You can use the PA one sheet to get the best deal, the biggest raise, and to help your confidence walking into your next negotiation. Head to www.tracybingaman.com/one, that's ONE, to download your free copy of the PA Pay one sheet and start prepping for your next negotiation today. It's linked in the show notes, but in case you missed it, it's at www.tracybingaman.com/ONE.
So I came into work. I had these plaques on my desk, and they were from the FDA. And it said UMass is has been identified as the institution that is affiliated with recognizing this medical device issue, which led to a class 2 medical device recall. No, 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 nothing. No, no. I had no idea who they came from. They were just on my desk. And then in August, I got an email and it said, "You have been identified as a Josie King Hero Award winner." And it was just I didn't know I won the award. It just said, like, you were nominated. And then there was an interview, like an invitation to attend a virtual meeting in 3 days. And I got on the meeting, and it was like the heads of the heads of the heads of the C-suite, people. And I won the award. And I had no idea. It was just like the most baffling experience to me. Like, nobody talked about it for 6 months. And then you win this award, this like national award. And I mean, it was just a wild experience. And then to add on that, then to get featured by AAPA a year later during PA week, it was just like the highlight of my career. But still, nobody's talking about it at my
Weird, right?
institution. It's just
Yes,
like the weirdest thing.
yes, it's so strange. Yeah, yeah.
Yeah, yeah.
And also, it makes me think about like how we could do that differently, right? So like someone identifies something like this, and that organization, I think in healthcare, we're not great. We love evidence-based medicine, but we're honestly not that great at providing it. We're not that great at pivoting. I think we're slow to adapt. And so like, what could that have been like? It could have been them celebrating you. It could have been them highlighting you at your campus or within your group. But also, and I think this but also is really, really important, looking at the process and saying, hey, this was hard for you to get to where you needed to be so that this could be appropriately reported and dealt with. How can we make that better for next time? Because as we'd all like to assume there will be no next time and this was a once in a career thing and like it's never going to happen again. And that may be true for you, but that's not true for all of healthcare, right? So like
No,
reporting to risk management and having them do nothing is not okay, right? Trying to get your, direct supervisor to do something and them not doing anything and you having to go above them and a push and push. Like, I'm glad you did it. It shouldn't be that hard. It should be one phone
no.
call that reports this, that triggers a whole cascade of events that keeps patients as safe as possible.
And I just wonder, hindsight, have thought about this so many times and thought if I would have done anything differently. And I don't think I would have, because I did what I was supposed to do. I was following protocol. But when the protocol was failing us is when I really, I had to intervene. But I will say, and, I did feel very, I didn't feel like there was any sort of retaliation by my institution. I felt like they were very grateful, and they're very, very supportive after the fact. But I just felt like uh, the process of getting there, and I think maybe my own understanding of what these different groups and departments and what their role was, really changed. Because when I had to utilize them myself, I was like, okay, this is not, this is what I thought they did, but this is what they really do. And so like I was thinking that they were there and I tell them the information and they take it from there, and then it's in someone else's hands, and they're like, no, 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 actually, we're here, like, we can teach you like what to say. We can help you like navigate that, um, but actually you can't do it as the PA. Like, it can't be you. It has to be somebody above you. Like who? I said, like who? Well, this person, or this person's not here anymore. Oh, okay. Well, then it was just like this. Yeah.
I know. I do feel like that's been in my career, especially working inpatient surgery. There's been a couple of times that, like, myself or one of my surgeons would say, "Hey, I think we need to talk to risk management." And I'm like, I don't feel like we have a good idea of like what they do or when we should call
Yeah.
them or what they're going to give us when we do call them. Like, we always,
Yeah.
and I'm also felt like we would always say that real late. Like, we would be like, way, like, like way not over our heads, but
Yeah.
like, oh, the situation's really going downhill. Then we're like, I think we should call them. I'm like, should we have called them
Yeah.
sooner? Like, I don't know.
Probably should have called them 2 weeks ago, but yeah. No, I agree, and I also think my joke recently is we're not entirely clear on the process. Like, I think that's like, we're not entirely clear on the process. That's like just my line lately.
And I think there's a lot of that unknown. There's a lot of that lack of transparency where people sort of like get oriented. And in the handbook, it says like, call so and so if something happens. And then it's years later, right? It's years later. You don't remember. That guy doesn't work there anymore. That department has a different name. Like, what, So, like, how
That's
are we
right.
making sure we know if this happens,
That's
who we
right.
call, like the compliance officer, whatever it is?
Yeah.
Everyone should just like take a moment to refresh. Who do I call and what would we do? And if you don't know, next time you have a department meeting, ask, hey, if we have a concern about safety, who do we call and how do we get a hold of them? And honestly, your direct supervisor may very well not know, but they could find out, right? You could start
Yeah.
the process outside of an emergency, outside of needing to get a hold of someone where you're like, who do we call if this
Yeah.
happens?
And I do think like part of the issue was that we were also in the middle of a pandemic. And that definitely played a role in everything. So I think that as post, like, we're coming into like post COVID, we're definitely not post COVID burnout. I think we're only like just starting that. That's just my personal opinion. We could have an hour-long discussion on that. But also, just now that things are getting back into full swing, taking a moment, stepping back and saying, what is the process? Like, let's get back to basics. Like, let's update the protocols and the processes that we have, and make sure that we know who those contact people are. And it doesn't have to be a big long hour meeting, but at least if we can update our contact sheets, like, update our department algorithm. um you know I think those things would be very important, not just in my department, but I'm sure nationwide at this point, with you know the mass resignation, or the great resignation as they're calling it.
Yeah.
I
I
know a
think
lot of
that
things have changed.
it's just like things are changing, and if you're not updating the way that you're doing things, you're behind, and then when you go to do it, you have to
Absolutely.
catch up at that point. It's easier to do it in advance of the crisis than to do it while you're in the midst of reporting the crisis, for sure.
Yeah. And for for me, this experience really, it showed me something that I enjoy doing, which is process improvement. And I have been so fortunate, like with the innovation station, and then like the meeting that I had gone to yesterday, and just it's almost like my first time as an adult being with other adults that practice medicine, but might not practice in a clinical setting. Um, it's just been a really inspiring experience. And then, and still thinking, like, at 37, I'm still figuring out what I want to do when I grow up. Like, what do I want to do when I grow up? And I certainly want to be a PA, but I feel as though my reach is more than what I'm delivering at this exact moment. And I think that's one of the great things about being a PA, is that we do have this kind of flexibility to be able to help out in areas that might not traditionally have been considered roles that physician assistants fill.
Yeah. Yeah. I think personally that our profession is on the cusp of like puberty. Like I feel like we're like getting
Yes.
ready to grow all the way up and that there is going to be opportunities and they're going to see PAs in C-suite roles, in executive roles, in roles of, creative design and process improvement and all of these things that like our clinical skills will not be directly applicable. We're not putting in ports as the CMO, right? But however,
That's right.
that those clinical skills and abilities, that our ability to communicate and problem solve and think critically, all of those things will apply in those new roles, which to me is so exciting. It's so great to see
I
people like
agree.
I'm almost, I feel ready. I feel like I have gained the respect. I feel like I have figured out what I'm good at, what I enjoy, and it might not be bedside procedures. And I think that that reminder that that is not a failure of you as a provider, right? That is you saying, hey, if I do this, I can impact so many more patients. I can improve the, care that we're delivering. I can improve the patient provider relationship. I can just make things better for so many more people than I would ever be able to see at the bedside one at a time in the next 20 years is so
Yeah.
important.
Yeah. And I think also us taking away like I have a colleague that currently the Massachusetts Association of Physician Assistant president, and we were talking about like what his next steps are going to be. And he said, I really want to do something in politics, and I think that I'm like, and my first thought is, you're going to leave medicine, like you traitor, like you're going to leave clinical practice. But then having that ability to see like but he said, but my impact could be so much greater on from this level. And I'm like, oh yeah, you're totally right. But it's like this whole but you're leaving clinical medicine, like that you're leaving the traditional role. But I agree. I and also, just to expand upon that, that's something that we did recently. We had we created a PA leaders task force for like as a spinoff for Massachusetts Association of Physician Assistants, and it was absolutely incredible because the people that came were all pioneers in their field, and they were all PAs from our state. And I was in the room and I had chills. Like I was just so grateful to be surrounded by these like-minded individuals that were thinking outside the box though. And pushing our profession to, you know, what showing what we can do.
Yeah. Yeah. So, so important. And I think it's just a good reminder that when you feel that curiosity, when you feel that tug to do something else, and even if you don't see anyone else doing it. So, part of the reason that this show exists and that we get to highlight PAs just like you is because I want to show people like this is what people are doing. Like, it's not only clinical medicine. There are so many other aspects of what we can do. But also, if you don't see it, it doesn't necessarily mean that you can't do it. It means that you don't know
So
someone
true.
else is doing it yet, or you don't know who's doing it yet, but you could be the first one. And we need a first one of that thing that you are curious about. We need a first PA who goes out and figures it out and doesn't do it perfectly, but does it anyway. It's just so important. It's the way that things move forward. It is, I mean, I think we could talk about it all day, but it's just so great to like tune into that curiosity and feed it. Like, don't discard it. If you're like, oh, but I really like process improvement, but I don't know the first thing about it. Like, so what? It's fine. You can figure it out. You've figured out all the things you've done so far in your life. You can figure that thing out. And that curiosity is not nothing. Like, listen to it.
Yeah. And I cannot speak like enough about networking and how important networking and having um, good mentors are. Not necessarily even mentors within your field or your scope, but like just it can be anybody. But it can be as long as that person is somebody who motivates you and encourages you to be the best that you can be, And I think sometimes it's great to have that perspective of someone who has absolutely no idea of what the healthcare side of things is. And that is part of the experience that I've gone through after, my life, the day my life changed, if you will. And just I've really forced myself to grow and make those connections and, realize I have a voice. My voice matters. I know what I know, and don't doubt yourself. Speak up when you know something's wrong, and go change the world. After that, like
Yes.
get out there and do you.
Yes, that is such a great reminder. I think that is a really great place to wrap up. But if people are like, hey, I need more of Thea in my life, I need to follow what she is up to and see all the great that she is doing in Massachusetts, where is a good place for them to connect with or find you online?
Sure. So LinkedIn would be a great place. Just Thea Nolan. You can find me there, and I'll share my information with you. And also, I'd be happy to share my email.
Sure. Yeah, we can put it in the show notes. Yeah.
Okay. Yeah.
Awesome. Well, thank you so much for sharing your time with us today. This has been a blast.
Yes. Thank you so much for having me.
I just love an episode and an interview that reminds you that you know what you know and that you have a voice that is powerful and strong, and a reminder to use it when you see something happening around you that is a threat to patients or a threat to culture or just downright wrong, that you have the ability to use that voice to create real change within the crazy, crazy system that is working in medicine and healthcare currently. Thank you, as always, for tuning in to another episode of The PA is In. This PA is out. Congratulations, you've just joined an awesome club. By listening to a full episode of The PA is In, you are officially on the Unicorn PA team. Welcome aboard. What most team members do is they subscribe to the podcast because that allows them to automatically get the latest episode of the show. The life of your dreams exists on the other side of taking action. Keep making small shifts and keep getting better. Your life will improve, your career will soar, and you will have the confidence you need to create your own success. I will see you in the next episode. This PA is out.